today's talk is entitled "Why Should I Get a PSA?" because I wanted to really personalize it for a patient.
What was your previous assignment? Where were you?
I went to medical school in Loma Linda, California. I was in the Navy for 9 years, stationed in Japan and Bethesda, Maryland, and Portsmouth, Virginia. And then I practiced in Vancouver, Washington, in the Portland area, and then most recently in Sacramento. Grew up in Wenatchee, so got back to the Northwest where I wanted to be.
Good place.
Sorry. So there's been lots of controversy about prostate cancer screening for some time, and this really came to the head in 2012 with a statement released by the U.S. Preventative Services Task Force. This is a government-sponsored group that puts out recommendations on preventative care, screening kinds of things. And they put out a statement in 2012 recommending against PSA-based screening for prostate cancer. Previously, in 2008, they had said that there was just insufficient evidence to make a determination. So this statement obviously caused lots of controversy in the medical community. The task force basically concluded that there was more men harmed than benefited from prostate cancer screening, and they felt that we just needed a better test and we shouldn't screen people until we got a better test. What's important to keep in mind is this is based on a public health perspective, so they're really looking at the population as a whole and saying we don't think this test is as effective as we'd like it to be, and making recommendations for basically the whole population. And there were two major trials that they looked at in their when they looked at evidence, a trial from the U.S. and a trial from the European community, and that's how they based their recommendations, was really based on those two trials. Again, it's an independent voluntary body, but it is sponsored by the U.S. government, and it basically has primary care as its mainstay. There's really no urologist, oncologist, any subspecialists or surgeons of any kind, any medical oncologist. This is really a primary care kind of look at different screening things, whether it's breast cancer screening or how we should treat hypertension, diabetes. So it's really a primary care look at recommendations. What makes it important is in the past, Medicare has used their recommendations to guide whether they're going to pay for something or not. So obviously, everybody was concerned what's going to happen in 2012 when they decided that they recommended against PSA-based screening. At this point, Medicare has not changed its funding for PSA screening, so it's still a covered entity. They've not decided to go in the direction of defunding that part of medical care. In contrast, the American Urological Association, which myself and all urologists are part of, recommends against screening in men under 40, but recommends informed decision-making in men between 40 and 55, really looking at family history and especially African-American race, groups that have higher risk of prostate cancer. You need to at least think about screening. And then they recommend screening between 55 and 69 years old, but again, taking into account risks and benefits of screening and a personal patient's preferences about screening. And then this is new in the last recommendation that's come out from the AUA. They've changed it from annual to every 2 years because that may decrease some of the harms of doing screening. And then they recommend, importantly, men over 70 or that have less than a 10-year life expectancy not to get screened. So are you confused? You got people on both sides of the coin telling you what to do. Well, to make it more confusing, we got the American Academy of Family Physicians. They basically follow the task force and recommend against prostate cancer screening. We have the American College of Preventive Medicine that says that you just have insufficient evidence to make a recommendation, and they recommend that if you have increased risk factors, you really need to talk about it with your doctor and just individualize it basically. American College of Physicians does something more similar to the AUA, recommends informed decision making between 50 and 69, and that people are less than 50 at average risk or over the age of 69 or have a low life expectancy shouldn't be screened basically. American Cancer Society recommends again informed decision making, and you see the 10-year life expectancy thing again show up in their recommendations. Again, they talk about the high-risk populations maybe need to be screened sooner than later, and they also, unlike some of the other recommendations, actually put a cut point for PSA on when they think you should screen as far as how often, 2.5. If you're over that, they want you to screen every year. If you're under that, they say screen every 2 years is probably reasonable. So, are you confused? I'm a provider, and it confuses me, so I can certainly understand how a patient would be confused by all this information. Some of the key things to think about is informed decision-making has really become a key with prostate cancer screening and probably healthcare in general. And that's why, again, I've entitled the talk, Why Should I Get a PSA? So let's back up a little bit and get a little perspective. Prostate cancer is the most common cancer in men and the second most common cause of cancer death. So we are talking about something that's important. So even if we have controversy about how we should screen and look for prostate cancer, it is an important thing to be talking about in the first place. And importantly, prostate cancer has no symptoms in its early stages. When you get symptoms, it's not a good thing. So we really have to figure out how to find prostate cancer early, and that's the point of screening, is to pick it up before it gets bad. In 2014, about 250,000 men will be diagnosed. This is new diagnoses of prostate cancer. Yes, sir?
What are some of the symptoms of prostate cancer when they finally do show up?
So prostate cancer, if it shows up, you're going to have symptoms from basically spread of prostate cancer. So you can have bony pain from spread to the bones. You can have obstruction of other organs, obstruction of the urinary system, making it hard to pee, pelvic pain, significant difficulty urinating. But those symptoms are really late in the course of prostate cancer. We're talking about metastatic stage 4 prostate cancer by the time it has symptoms.
So,
There's nothing really up front, unfortunately. And about 30,000 men will die of prostate cancer this year. So again, it is a significant health impact. This is just a graph looking at epidemiological evidence showing a change in incidence over time. So by race here and all men, you can see up into the 90s, prostate cancer incidence peaked, and in the last 20 years, its incidence has been actually decreasing despite the aging population. So that's an interesting finding over the last 20 years. Nearly 20 million men, so we talked about 250,000 will be diagnosed, but unfortunately 20 million men will have to consider what they want to do about prostate cancer screening because they're in that age group that's considered the highest risk. Overall, men have about a 1 in 7 lifetime risk of being diagnosed with prostate cancer and a 1 in 30 lifetime risk of dying of prostate cancer. And this is really probably that number, those two numbers are probably what gives you the best idea about where the controversy comes in. So lots of men get diagnosed with prostate cancer, but the diagnosis of prostate cancer doesn't mean you're going to die from prostate cancer. So it's separating those two. Who do we need to treat? How much do we need to treat them? And trying to make those decisions is really where the crux of the problem comes in. So high-risk populations, African American men have a much higher risk of prostate cancer and aggressive prostate cancer. And then obviously anybody with a family history. First-degree relatives are more important, and the age at which your first-degree relative got prostate cancer is important as well. So if your dad had prostate cancer in his 80s, that's less of a risk than if he was 55. Your risk then is much higher. Over the last 20 years, we've seen death rates fall by about 45%. Some people argue about those numbers, and I'll show you a graph that kind of shows that in a second. But many people argue that there's been a decrease in prostate cancer deaths because we've done things to detect prostate cancer earlier and because we've improved our treatment options over time. So this is a graph, again, from that same database looking at population as a whole, and prostate cancer deaths were steadily increasing. There's this kind of spike that some people have a hard time explaining. So if you were to cut that out and just look at the general trend of prostate cancer deaths, you can see that it looks like it's peaked in the early 2000s, and then in the last 10 to 15 years, we've seen a dramatic decrease in prostate cancer death. The 45% number comes from this peak up here going down to here. It's probably about a 20% decrease in prostate cancer deaths if you use the lower peak. But there has been a trend. We've been improving survival in prostate cancer, especially in the last 10 to 15 years. So the question is, why is that? There's lots of arguments about why that's happening. Many argue against screening because they're concerned about the diagnosis of all those people who have low-grade, small-volume cancers and may never need treatment or may not benefit from treatment. So they talk about overtreatment and the side effects that are associated with treatment like surgery and radiation. We also talk about the patient anxiety, patient discomfort from false positive biopsies when you're told you have an elevated PSA, and then you end up getting a biopsy, it's negative, but you have to go through that whole experience, which isn't fun for a patient. And then the complications and costs of even negative biopsies, things like infection, bleeding, those kind of things. So again, what is PSA? Get a little more perspective on where this is coming from. PSA is a protein, a substance that's secreted by the prostate, and it has important functions. Early in life, when we're sexually active and interest in fertility, that's when PSA is really helping us. PSA is found in the ejaculate, and it helps enhance sperm motility, and it also helps the sperm enter the uterus. It's found in very, very small amounts in the serum, and that's what we're using when we pick it up as a test. It was found in earlier studies in the 70s and early 80s to be correlated with prostate growth and prostate cancer, and then the first test was actually commercially available in 1986. And then after that became widespread in the medical community. One of the important things to understand is there are lots of tests available that check PSA made by different manufacturers, and they are not interchangeable directly. So if you go from one lab to the next, if they use a different method, which they may or may not, but if you go from one lab to the next, you're going to see differences in your PSA. Not huge differences, but you will see fluctuations in the PSA number, even if you did it on the same day by different labs. So that's an important thing to keep in mind when you're following a patient, knowing where they had their previous PSAs. If they have an aberrant one done from a different lab, sometimes that could just be a lab difference. You need to kind of recheck those kind of things. Things that affect your PSA, besides prostate cancer, infection, urinary tract infections, trauma to that area, ejaculation can even affect it. So they talk about the best test being with 2 or 3 days of abstinence. That's not in every patient, but some patients that can affect their PSA. Recent instrumentation, things like cystoscopy or catheters, can cause the PSA to go up because of irritation to the prostate. And then medications, probably the most important in urology, are Proscar and Avodart, but there are other herbal supplements and things like ketoconazole, which is used to treat fungal infections, that can also impact your PSA level and then confuse interpretation. PSA does correlate with prostate cancer, but an important thing to understand is there's no PSA that absolutely has no risk of prostate cancer. So in a large screening trial called the Prostate Cancer Prevention Trial, they did biopsies on all men at the end of the test, or end of the trial, and they found about a 15% incidence of prostate cancer, even with PSAs less than 4. That kind of classical number you see on lab tests, 0 to 4 is supposed to be the normal range. Even less than 4, there is a small risk of prostate cancer, but you can see the risk goes up dramatically when your PSA rises. So between 4 and 10, there's about a 30 to 35% risk, and if you're over 10, the risk is over 60%, and the higher it goes, the more the risk increases. So risks of prostate biopsy. Patients certainly can have pain. We do our best to try and improve this, and certainly doing periprostatic blocks with local medication has dramatically improved patients' tolerance of prostate biopsies, but there is still pain associated with it. There can be voiding complaints, difficulty urinating after the procedure. Most of these things are self-limited. Urinary retention is very rare, less than 1%. Bleeding, while blood's found in the stool and urine and semen, for most patients it's not a significant amount of blood loss, and it's not really a major concern, but there is blood found in those areas after a biopsy. The most important thing that we worry about is infection, and the unfortunate thing with this is that, as with all antibiotics and infectious use in the last 20 years, we've seen a rise in infections and resistant infections. So in 1996, the hospitalization rate was about 1% after prostate biopsy, and in 2005 it had risen to 4%, and it's probably closer to 5 or 6% at this point based on resistant infections. So we treat patients with an antibiotic around the time of the biopsy, and they can still get an infection because of resistance that's developed to a lot of the antibiotics we use. So where did, again, the information that people have made these recommendations come from? There's 2 major studies that they've looked at. We mentioned the European study. It was 180,000 men in 7 countries, and they did screening a little different than we do it here in the U.S. Every 4 years with a PSA, and prostate cancer death was the main outcome that they were looking at. They did find more cancer in the screen end, and importantly, they did find less death, or have less death from prostate cancer in the screened population compared to the unscreened population. And you can see those numbers are not huge. So they screened 180,000 men, and they had 750 people die during the study period. So prostate cancer, again, is slow growing overall. Lots of men may have prostate cancer, but your risk of prostate cancer death is not huge compared to some other kinds of cancer. So they did statistical modeling, and basically there was a 21% risk reduction by being screened. And then another calculation that was important, that plays into people's recommendations, is they calculated that it took about 1,000 men to be screened and 37 to be diagnosed with cancer to save 1 life. And that's where these value judgments come in as far as whether we think screening is important or useful for patients to do. Some flaws of this test. So there's no perfect test, unfortunately, no perfect study. And some flaws of this study that are important to consider: many of the men were over 60 years old when they were screened, which is a little bit older population to be starting screening at, so you may not have caught prostate cancer at an early enough stage. 20 to 25% of the people who were supposed to be in the control group and not be screened had a PSA anyway, so that kind of contaminates your control group. They had a pretty good biopsy rate. 86% of men who were recommended to have a biopsy did have a biopsy, but they did an older form of biopsy, what's called a sextant or 6-core biopsy, and that's fallen out of favor in the last 10 to 15 years. We now use as a standard 12-core, and actually there's newer evidence saying maybe we should be doing 14 or 16 cores to get better detection of prostate cancer. So they may not have picked up all the prostate cancer in their study, and again, the PSA interval was every 4 years. And the treatment has evolved since this study was really started in the 1990s. So those are some potential flaws that may skew some of their results. The U.S. test was 76,000 men in 10 U.S. centers, a little bit different age group. They did PSAs every year and a rectal exam every year for 4 to 6 years, and then they followed those patients after that. And their statistical analysis was there was no difference between the two groups. Well, it's important to consider some of the flaws with this test when you look at their results. 40% of the people that they had in their control group had a PSA before the test even started. So they weren't really an unscreened population. And then 75% of those control group had at least another PSA once during the rest of the study period. So again, they weren't really an unscreened group that they were comparing to. And only 50% of those who had a biopsy recommended actually got their biopsy performed. So many critics say this really isn't a study comparing no screening to screening. It's comparing screening at some stated interval to somebody just getting kind of random or opportunistic PSAs whenever their primary provider decides to do that. So some other important things that it didn't address high-risk populations. Patients with family history and African American men were a very small percentage of the population of those studies, so we didn't get a lot of information about those men in that study as well. Again, at publication, the European study showed those numbers of 1,037 needed to save one life. After collecting more data, after they initially published things, they came up with a new number of about 200 men needed to be screened and 5 needed to be diagnosed to save one life, which is much better statistics and ratio. A subsection of that study actually showed a 32% risk reduction. This is the Rotterdam section. And if they took out the men who didn't comply with recommendations for screening and didn't follow up, then their risk reduction, if they did do screening, was about 50%, which is, again, more dramatic than initially was seen. An important smaller study that was not included in a lot of groups' recommendations is a study out of Sweden. A lot of the patients were actually included in the European study, but this study was designed before the European study, and it was conducted independently, and so it was its results were reported independently. It's an interesting population because it's probably the cleanest study that's been done at this point. They took 20,000 men between 50 and 64, and they did screening every 2 years or nothing. The background screening in Sweden is very, very low, so the population in general does not get PSAs on a regular basis. So only 3% of the background population had a PSA done, and they're actually still accruing follow-up data. Their odds ratio or risk reduction for prostate cancer was 0.56. That means they had a 44% reduction in prostate cancer death in the screened group compared to the unscreened group. And again, their number to treat was 298, and 12 needed to diagnose to prevent one death. So much better numbers and more similar to the reevaluation of the European study. So again, some reasons why this one's different. The screen population was younger, they had less contamination, they had a lower PSA threshold for recommending a biopsy, and they had men screened more frequently than the European study and longer than the US study. Some unanswered questions that haven't been looked at in any real study at this point is at what age should we start testing? Most of the studies looked at men between 55 and 69. There's some smaller studies that show that getting a PSA earlier in life may be predictive of your later risk of prostate cancer. And they seem to correlate better even than ethnicity or family history for later risk of prostate cancer. What's the ideal interval for testing? Standard has been once a year. That's sort of been the standard in the US for the last 30 years. But there's evidence from both computer modeling and from the other studies that if we go too long, it's not good. But every other year may actually dramatically reduce the risk of having false positives and some of the side effects of doing prostate biopsies and screening rather than an annual screening program. At what age should screening stop? This is really controversial because we're really looking at those recommendations in each of the groups talking about 10-year life expectancy. Everybody agrees with that number. 10-year life expectancy is needed to see benefit from prostate cancer screening. The problem is, how do you estimate someone's life expectancy? And studies have shown physicians are notoriously bad at estimating a patient's life expectancy, and we tend to undervalue their comorbidities. We look at somebody and think they're going to live longer than they really are, or vice versa. So it's really hard for us as physicians to make a good recommendation for patients based on life expectancy. There is some data looking at screening to age 75. The advantage of doing that would we would increase the probability of saving a life by about 27% because we're going to pick up more high-grade cancer, which tends to occur in older men. But the downside is we're going to increase our overdiagnosis of low-grade cancer by 50%. So there's trade-offs to everything, unfortunately. But this is, again, a big area of controversy because most of the recommendations at this point recommend stopping screening at age 69. And certainly as a practitioner, I can tell you I see lots of men over the age of 70 who have prostate cancer and potentially have symptoms from metastatic prostate cancer. So that's an area that we're still trying to figure out what the right thing to do is for men. So my preferred recommendations, I showed you lots of different recommendations at the beginning. My preferred recommendations actually come from the National Comprehensive Cancer Network. This is a group that is made up of not only urologists, but also radiation oncologists, medical oncologists, statisticians. So there's a kind of a little bit broader spectrum of providers making these recommendations and kind of looking at the data. The key thing for them to start with is their guidelines are for men who have opted to proceed with screening, so they think certainly it's important for men to have an informed decision-making process with their providers and talk about the risks and benefits of screening. And then if they choose to do so, then they make recommendations on what they think is probably the ideal way to screen patients. So if you're less than 50, they recommend getting a baseline PSA, and if it's very, very low, less than 1, then you don't need to check again until you're 50 because your risk of prostate cancer is very low. If it's over 1, then they recommend continuing screening every 1 to 2 years. Between age 50 and 70, the cut point is PSA of 3. If you have a PSA less than 3, then you just do screening every 1 to 2 years. If your PSA is over 3, then they talk about potentially doing a biopsy. And then again, over age 70, they're looking at patients' overall health. Some of the important data that helps them make their recommendations comes on this slide right here. If you are a 60-year-old man and your PSA is less than 1, your lifetime risk of dying of prostate cancer or having metastasis from prostate cancer is very, very low. That doesn't mean you're not going to get prostate cancer, but it means even if you develop prostate cancer, if you start with a PSA of less than 1 at 60, your chance of dying from prostate cancer or having spread of prostate cancer in your lifetime is incredibly low. So those men probably don't need to be screened rigorously because they're not going to see the advantage of it. And another important number, again, it's at 75. If your PSA is less than 3, very similar. If your PSA is less than 3 at 75, you're very unlikely to develop symptomatic prostate cancer or die from prostate cancer in your lifetime. That comes from a study in Baltimore where they looked at about 850 men, and none of the men who had a PSA less than 3 died from prostate cancer during the study. So the National Comprehensive Cancer Network looks at, again, a couple of things to recommend a biopsy. One is if your rectal exam is suspicious. That's always been a recommendation if you have an unusual rectal exam. I think that's important to do a prostate biopsy. Most prostate cancer at this point is actually not picked up on rectal exam. So if you have something palpable on rectal exam, that's more concerning than an elevated PSA. And then PSA over 3, that's the next thing. And then multiple risk factors, things like your ethnicity, your family history, potential PSA velocity over time, those kind of things play into a decision on whether to do a biopsy. And then you have options still at this point. You can do a biopsy, you can repeat a PSA and rectal exam at some interval, and they recommend 6 months, or you can consider alternative tests to help you get more information about whether you want to do a biopsy. Some of the important alternative tests that give us the most information are percent-free PSA. So you may have heard of percent-free, had that done by your doctor before. And there's a range of percent-free that we look at as being low risk and higher risk, and the highest risk population is a percent-free PSA of less than 10. And then there's a couple other tests. PCA3 is a urine test that's done after a prostate exam, And if you have a high PSA3 score, that's an increased risk of prostate cancer, and that's another thing that they recommend doing a biopsy for. And then prostate health index is just looking at some calculated numbers based on all the different kind of subcomponents of PSA and getting a risk from that. I want to spend just a couple minutes talking about PSA after prostate cancer. So I've talked mostly about prostate cancer screening, and certainly there's controversy about PSA's utility in that scenario. PSA after prostate cancer diagnosis is very different. It's very predictive of survival, of outcomes, and so in that scenario it's a little bit different. So I wanted to spend a couple minutes talking about that as well. So pre-treatment PSA predicts your response to cancer, or the prostate cancer's response to local therapy. Basically what we're talking about is the higher the PSA at the time of diagnosis will give you a sort of risk stratification for finding cancer outside the prostate, in the seminal vesicles, or in the lymph nodes. So PSA is very important in those men. Once they've made a diagnosis of prostate cancer to predict the likelihood of prostate cancer spread. PSA is also important in looking at whether or not a bone scan is useful. So at least for me, when I talk to patients about prostate cancer, the second question is always, what imaging studies can we do to figure out where the prostate cancer is? And this is a major guide for when to do a bone scan. And the numbers really come right here in the center. If your PSA is less than 10, your risk of having a positive bone scan is very, very low. So certainly if your PSA is less than 10, there's really no utility to doing a bone scan. If it's over 20, most experts would agree that you should do a bone scan. Between 10 and 20, the risk is about 5%. And things like your Gleason score or how palpable your prostate cancer is will determine whether or not a bone scan is going to be more predictive for those patients. CT scan and MRI can be considered for staging if your PSA, again, is over 20 or your Gleason score is 8 or higher. One of the downsides of CT scan and MRI is that even in the best case scenarios, they only pick up about 30 to 35% of lymph node metastasis. So you can unfortunately have a negative CT or MRI and still have cancer in those areas. They're just not as good at picking up lymph node spread. Pelvic lymph node dissection, and this is important clinically, pelvic lymph node dissection or treatment of the lymph nodes with radiation therapy is not indicated if you have a Gleason score of 6 or less or your PSA is less than 10, because the risk of having cancer in the lymph nodes is on the order of 1% or less. So it's not considered useful to treat 100 men to try and help that one patient with potential lymph node involvement. PSA after prostatectomy should essentially go to 0. That's, again, important when we follow patients. We're looking for that PSA to essentially go to 0. 0.2 is the number that we look at as far as making a determination of someone having a recurrence. And the reason we use that cut point is that most of the PSAs at this point are what we call ultra-sensitive. They can pick up very, very minute amounts of PSA. And your PSA is made by some of the urethral cells that can be left over after a prostatectomy. So you can have very, very minute amounts of PSA that are not associated with prostate cancer. But if it rises above 0.2, then that's considered a recurrence. And once that happens, the average or median interval of life expectancy is about 5 to 12 years after you've had a PSA recurrence. This is after a prostatectomy. When you talk about other therapies that leave the prostate in place, things like radiation therapy, cryotherapy, HIFU, which is not done outside of studies at this point in the U.S., but these therapies leave the prostate in place. So the PSA never goes as low because you have prostate with residual tissue left in place. And it can be a little more difficult to follow PSA after these kind of treatments because in the first 2 years you have something called a bounce phenomenon, where there's tissue that's dying, prostate cancer tissue is necrosing, and the PSA can spike in the first 2 years after treatment, and then it'll drop back down. And then the last thing is PSA after hormone suppression for metastatic prostate cancer. And this, again, is a very important number to look at. If you are diagnosed with metastatic prostate cancer, what your PSA does in the first 6 months after diagnosis really determines your life expectancy. So if the PSA goes down essentially to 0 once you get put on hormone therapy, then your median survival is about 6 years. If it goes down between 0.2 and 4, survival is about 3.5 years. And if it never makes it down below 4, then your survival is about a year on average. So that is really predictive. What a PSA does after we start somebody on hormone therapy is really predictive of their survival when we talk about metastatic prostate cancer. And that's all I have. Is there any questions that I can answer for anybody? I know I've covered a lot of stuff and thrown a lot of information at you, but if there's any questions that I can try to answer for you, I'm happy to do so. I'm sorry, did you raise your hand?
I did, I got in a little late.
Sure.
But my question was, with a family history, father, uncle,
Right.
and a low PSA score, less than 3, can you still do the every other year? Or does the family history suggest do it every year?
I think, at this point, there's not a lot of steady data to tell us for sure how to look at that patient. I think from a provider standpoint, I would feel more comfortable with annual screening. You're talking about 2 first-degree relatives. So if you talk about a grandfather or a great uncle separated by 2 generations, your risk is lower. A first-degree relative and having 2 of them increases your risk probably somewhere between 2 and 8 times over the standard population. So personally, if we're going to pick it up early, we want to pick it up before it shoots up dramatically. I would say annual screening is probably better. Any other questions?
Did you read about the study in the Wall Street Journal this morning about male pattern baldness?
I saw a little blurb come across my phone that male pattern baldness, certain kinds of male pattern baldness were associated with prostate cancer. I didn't read the study.
39% increase in an aggressive form of prostate cancer. Never seen that before.
The problem with a lot of those studies is you're looking at associations, and we don't understand the association. So whether it's causative or just kind of happenstance that you have an association between male pattern baldness and prostate cancer, that's something that's going to take a lot of effort to elucidate. But one of the theories that could be going on behind that is male pattern baldness is associated with higher testosterone levels in the peripheral tissues, and prostate is a testosterone-specific organ, so it could be related to your testosterone level and your potential risk for prostate cancer. But again, there's a long distance between making that kind of observation of baldness and prostate cancer and figuring out why that would be a real association and whether it's true or not.
Not real comforting though for some.
Sure. Well, it's not real comforting for me either. Anyone else?
I've noticed in the people that I associated with or used to work with, 4 or 5 of these men between age 53 and 68 have all come up with prostate cancer. And I just don't understand, just in a short period of time, in 6 months, these guys have all come up with it. And it's just, I'm kind of concerned about myself because I'm 67.
Sure.
And one guy had a low PSA, and the other guy had a high PSA.
Sure.
So it's kind of a crapshoot, basically.
Well, like the one slide I showed you.
But I think it's worth it. I'm going to do this. This is, I think, the best way to find out if I'm at risk.
Sure. I didn't spend a lot of time talking about it, but one of the things that I think is important for patients to consider is the difference between making a diagnosis and getting information and necessarily treating something. So in the past, historically, if you had prostate cancer, 90+% of men were treated for prostate cancer. And what we've discovered in the last 10 to 15 years is we probably have been over-treating men, meaning that there are a group of men who are at lower risk of, like we talked about, ever actually dying from prostate cancer or having symptoms from spread of prostate cancer. And we're trying to figure out, at this point still, how to separate those from the men who really are going to get a benefit from aggressive treatment like surgery and radiation therapy. So we've seen in the last 10 years a dramatic increase in the number of men who are on what's called active surveillance, meaning that we make a diagnosis of prostate cancer, but based on their PSA, their rectal exam being low risk, their volume of cancer on the biopsy being very small, we recommend against treatment. And that's really a paradigm shift in medicine and in urology. Is when I was training, you got prostate cancer, everybody got treated. Now, probably 1/3 of my patients don't get treatment, either because they opt not to after an informed decision making, or I actually make an argument for them not to get treated based on their age or their life expectancy, or certainly based on the aggressiveness of their cancer. The opposite is true as well, though, for me at least, is that I've, unlike the recommendations where they stop at 69, I actually screen men in their 70s based on their health. So if a 75-year-old comes into me and they're very healthy, active, very minimal medical problems, then I think it's reasonable to screen those men. And I've made diagnosis of prostate cancer again, once you make that diagnosis, you have the difficult decision of, is it worthwhile to treat that patient or not? And I'm really looking at how aggressive their prostate cancer looks and trying to weigh that with their potential life expectancy to help them make a decision on whether it's better to watch things and leave it alone or to treat it.
There's different types of, there's one friend of mine said he had 2 different types of cancer on the prostate.
So most people have a single type of cancer, prostate adenocarcinoma, but there can be different grades of prostate cancer based on aggressiveness. So there can be more aggressive portions of the prostate cancer and less aggressive
Which
portions.
is pretty much the same type of cancer.
Right. Anyone else? Yes.
I'm sorry, I came in a little late. Do you have any data on Asian men?
I don't have any in my slides. The studies on Asian men are, at this point, lower risk than the Caucasian population, and the African American populations have the highest risk. So Asian and Middle Eastern men seem to have a lower risk of prostate cancer, but I don't have those numbers off the top of my head right now. All right, if there's no other questions, yes?
Do any of the studies indicate that diet plays a role?
Sure, there's some population studies, which again are difficult to interpret because you're looking at a huge population. There's potential factors that are hard to control for, but there is some evidence that the Western diet, that a high-fat diet, especially with animal fat, seems to be correlated with prostate cancer risk. But that data, is not super strong. Some of the data comes from looking at populations like Asian populations that come to America, and the first generation doesn't have a very high risk of prostate cancer, but then second and third generations who adopt sort of the Western diet that we have here in the U.S. have a much higher risk of prostate cancer, and they think that that's related to not genetic factors, because again the population hasn't changed dramatically, but to environmental factors when they come to the U.S. and change their diet and the environment they're in. So there is some evidence that diet's correlated, but it's hard to elucidate at this point how much. So the main thing we recommend is animal fat needs to be decreased in the diet. There's been lots of studies looking at things like selenium, zinc, garlic, ginkgo biloba, lots of different supplements, tomatoes, lycopenes, and in small studies they seem to have some potential benefit for prostate cancer risk, but they've done some larger studies through NIH that haven't borne out, especially selenium and zinc. Blanking on the other one. There's another one they just tested recently that didn't bear out in a larger population study as far as herbal supplements. So at this point, we don't have a lot of great recommendations for diet, unfortunately.